Welcome medical students to this educational video on the management of primary postpartum hemorrhage, or PPH. This guideline provides evidence-based recommendations to anticipate, prevent, detect, and manage PPH effectively. PPH is the leading direct cause of maternal death worldwide. Our objective is to ensure timely and appropriate interventions to save lives. Let's begin with the definition. Primary postpartum hemorrhage is defined as blood loss of 500 milliliters or more from the genital tract within 24 hours of delivery. When blood loss exceeds 1,000 milliliters, it's classified as major PPH. However, cardiovascular instability, such as tachycardia or hypotension, indicates a major obstetric hemorrhage, regardless of the volume lost. Blood volume varies between individuals but can be estimated as body weight in kilograms divided by 12. For example, a 60-kilogram woman has an estimated blood volume of 5 liters. Losing 40% or more of this volume, around 2,400 milliliters in a 60-kilogram woman, is life-threatening and termed a massive obstetric hemorrhage. Prevention is the cornerstone of PPH management. Active management of the third stage of labor is critical and includes practices detailed in the guideline on third-stage labor management. Additionally, correcting anemia during the antenatal period reduces PPH risk. Predicting PPH is challenging, as it often occurs in women without risk factors. However, certain factors increase the likelihood, and we must be vigilant. These include grand multiparity, previous PPH, fibroids, anemia, pre-existing hemorrhagic conditions, anticoagulant use, obesity, preeclampsia, gestational hypertension, uterine overdistension from multiple pregnancies or polyhydramnios, a large baby over 4 kilograms, chorioamnionitis, and dengue infection. Abruptio placentae and placenta previa carry a particularly high risk. For every woman in labor, ensure her blood group is known. Women with risk factors should deliver in a specialist obstetric unit. Now, let's dive into the management of primary PPH. When PPH is suspected, regardless of the cause, act swiftly and systematically. Call for help immediately to assemble a multidisciplinary team, maintaining a calm atmosphere. Keep the mother and her family informed and reassured throughout. Assess and monitor her general condition, estimated blood loss, pulse, blood pressure, and respiratory rate every 15 minutes. Insert a Foley catheter to monitor hourly urine output. Assign a staff member to maintain a chronological record of the patient's condition and interventions, coordinating with other disciplines. Ensure intravenous access with 2 wide-bore cannulae, preferably 14 or 16 gauge. Send blood for cross-matching and a baseline full blood count. In cases of massive hemorrhage, consider additional tests like a clotting profile. Start Ringer's lactate, also known as Hartmann solution, to stabilize the patient. Identify the cause of bleeding promptly and keep the woman warm to prevent hypothermia, paying attention to the temperature of the labor room, operating theater, for fluids, blood products, and lavage fluids. Involve the anesthetic team early, even while the patient is in the labor room, and administer oxygen via a face mask at a minimum rate of 8 liters per minute, or 10 to 15 liters if suitable masks are available. If the patient's condition deteriorates beyond what's expected for the visible blood loss, suspect internal hemorrhage. Check the placenta for completeness. If incomplete or uncertain, consider uterine exploration under anesthesia. Inform the consultant immediately in critical situations, such as blood loss exceeding 1,000 milliliters, a pulse rate over 100 beats per minute, systolic blood pressure below 100 millimeters of mercury, a drop in systolic blood pressure by 30 millimeters of mercury, an increase in pulse rate by more than 30 beats per minute, rising fundal height, or deterioration disproportionate to overt blood loss. Next, establish the cause of bleeding. Palpate the uterine fundus to assess tone. A poorly contracted uterus suggests atonic PPH, the most common cause, but don't overlook possible genital tract trauma, which can coexist. Inspect the genital tract thoroughly for tears or lacerations, ensuring adequate exposure and lighting. If the uterus is well contracted, trauma is the likely culprit. For atonic PPH, initiate uterine massage by rubbing up the fundus. Clear blood clots from the cervical canal and vagina via vaginal examination. Administer uterotonic drugs to enhance contraction, either 0.5 milligrams of ergometrine maleate or 0.2 milligrams of methyl-ergometrine slow 4, or 5 international units of oxytocin 4. Start an infusion of 40 international units of oxytocin in 500 milliliters of Hartmann solution at 125 milliliters per hour via duct and infusion pump. Perform bimanual uterine compression to apply direct pressure on bleeding vessels. If bleeding persists after 5 to 10 minutes, repeat 0.5 milligrams of ergometrine 4. After another 10 minutes, if bleeding continues, administer 800 micrograms of misoprostol rectally or sublingually. If bleeding remains uncontrolled after another 10 minutes, proceed to uterine balloon tamponade and inform the consultant. Simultaneously, give 1 gram of tranexamic acid by slow 4 over 10 minutes, repeatable after 30 minutes if needed. Balloon tamponade is a critical step before surgical intervention. If your facility lacks trained personnel for this, transfer the patient to a higher-level institution after ergometrine and oxytocin fail, using temporizing measures like manual aortic compression or sandbags during transit. After balloon insertion and vaginal packing, monitor vital signs and fundal height closely. Persistent bleeding indicates the need for laparotomy, and the patient should be moved to the theater without delay. Before laparotomy, examine the genital tract for tears under anesthesia. Surgical options include brace compression sutures, uterine devascularization, hemostatic mattress sutures, box sutures for placenta previa, internal iliac ligation, or hysterectomy. The sandwich technique combines balloon tamponade with brace sutures. Hysterectomy should be considered promptly to avoid delays that contribute to mortality. Continue preventing hypothermia in the theater. For traumatic PPH, exclude high vaginal or cervical tears before suturing an episiotomy. Suture from the apex downward using a continuous technique. If the apex isn't visible, start at the highest point, pulling downward to reach it progressively. Check for paravaginal or broad ligament hematomas with combined vaginal and rectal exams. Manage individually. Paravaginal hematomas over 5 centimeters typically require surgical evacuation, seeking a bleeding point. A Foley catheter with an inflated balloon or vaginal packing may help control bleeding. Cervical tears require systematic inspection and suturing, but multiple tears with venous oozing may be better managed with a vaginal balloon catheter or moistened packs rather than suturing each tear. Suspect uterine rupture if the patient's condition worsens disproportionately to visible blood loss, especially with a scarred uterus and a contracted uterus. Involve a consultant immediately for surgical intervention. After stabilizing the patient, address psychological morbidity. A major PPH can be traumatic, so debrief the patient and family promptly, ideally led by the consultant, immediately after the event, before discharge, at the postnatal visit, or as requested. This comprehensive approach to primary postpartum hemorrhage equips you to act decisively, saving lives through prevention, early detection, and effective management. Thank you for your commitment to maternal care.